Hello.
Good afternoon, everybody. Welcome, Bhatnagar sir. So today we'll be talking about innovations and artificial intelligence in pediatric surgery. And to begin the first session, may I invite Dr. Vaibhav Pandey. He's an associate professor of pediatric surgery at BHU Varanasi. Dr. Vaibhav, please.
Thank you, ma'am. I welcome all the delegates to the second day of this virtual 6th annual conference of the research section of IAPS. We will be beginning with the first session. For the session, we have chairpersons. I'd like to call upon the chairpersons. Among those, first is Professor A.N. Gangopadhyay, eminent teacher, ex-professor of the Department of Pediatric Surgery, IMS BHU. I also happen to be his student. Sir is alongside me. He'll be joining with me. The second chairperson in the session will be Professor Amita Sen, ma'am. She is Professor of Pediatric Surgery at RML Hospital and Atal Bihari Vajpayee Institute of Medical Sciences, New Delhi. And I welcome Professor Prakash Agrawal, sir, Head of Department of Pediatric Surgery at Sri Ramachandra Institute of Higher Education, and also past Honorary Secretary of IAPS. So I will ask chairpersons to chair the session and hand over the proceeding to chairpersons for further.
Good afternoon, everybody. Thank you. Initially, I would like to thank Dr. Mahajan and Dr. Shilpa for giving me the opportunity to chair this session. And this session is very interesting because... Hello? Can you listen to me?
Yes, sir. You are very well audible, sir.
Okay. This session is of one speaker. He is definitely known to everybody because he is a multifarious person. He is doing a lot of work. People call that double engine, but he is having multiple engine, and he is having too much energy in his pocket. Anyway, Dr. Vijayan Kumar is at present head of the Department of Pediatric Surgery in the Institute of Medical Sciences, Patna. Besides this, he is also the member of Medical Education Board undergraduate studies, and also this is of National Medical Commission, Government of India. Besides this, he is also holding post of member of Institute Body of IAPS Raipur and IAPS Devghar. So with this little introduction, I would like to invite Dr. Vijayan to present his speak. His talk will be of 10 minutes and 5 minutes discussion. So after the discussion talk is over, I would like to request Dr. Amita and Dr. Prakash to conduct the questionnaire sessions, because 5 minutes time is more than sufficient for question answers. Now, Dr. Vijayan, please, you start your question.
Sir, before...
Yeah, can we hear two words from Prakash Agrawal? Yes, sir. Yes, sir. Please carry.
Yes,
sir,
yes. Carry on.
I may leave the meeting halfway because I have an important meeting to attend. So I just request the other two chairpersons to carry on with the proceedings.
Okay, thank you very much. Then Dr. Amita, you will conduct the questionnaire session. Okay.
Yeah, I'll do all of that, sir. Thank you.
Okay,
Let us hear Dr. Vijendra now. Am I audible, sir?
Yes, ma'am.
Yes.
Right. Dr. Vijendra, please.
Thank you, sir. सभी को नमस्ते. मैं डॉक्टर शिल्पा का जब फोन मेरे पास आया तो मैंने उनको कहा कि मैं 1 साल से क्लिनिकल वर्क से मैं दूर हूं और हेड क्लर्क का काम कर रहा हूं. तब भी उनके कहने से मैं आया, इसलिए थैंक यू टू शिल्पा, थैंक यू डॉक्टर जे.के. महाजन और मेरे गुरु डॉक्टर गांगुली, बहुत दिनों के बाद जिनको मैं प्रत्यक्ष देख रहा हूँ, और डॉक्टर अमिता सेन के साथ मेरे एमएस करने के बाद मैं पेरिफेरी में प्रैक्टिस कर रहा था और एमएस और एमसीएस के बीच में मेरे 10 इयर्स का डिफरेंस है. तो इसलिए पहला मौका मुझे डॉक्टर अमिता सेन के साथ मिला. उसके बाद मेरा सौभाग्य था कि मैं बीएचयू में पहुंचा डॉक्टर गांगुली के शरण में. तो आज जो कुछ भी पीडियाट्रिक सर्जरी में मैं कर पाया हूँ या जो समझ पाया हूँ वो इन्हीं लोगों के बदौलत है, और आज मुझे मौका मिल रहा है इनके सामने बोलने का, ये मेरे लिए सौभाग्य की बात है. तो मेरे कुछ विचार हैं, बहुत सारे लोग इससे सहमत नहीं होंगे, लेकिन मैं उसको रखना चाहता हूं. ठीक है डॉक्टर शिल्पा?
यस,
यू कैन सी. बढ़िया दिख रहा है.
नेक्स्ट ये आ नहीं रहा है ये।
आप अनशेयर करके वापस जब शेयर करेंगे तो जब पूरा पावर पॉइंट खुला नहीं हुआ उसको शेयर करना। अगर स्लाइड शो शेयर करते तो आगे नहीं खिंच सकता।
मैं फिर से करूं?
हाँ जी।
नहीं तो जो कीबोर्ड पे एरोज है उसको भी यूज कर सकते हैं।
ठीक है।
चूज करते टाइम पीपीटी चूज करना, प्रोग्राम नहीं।
आपको कर लिया।
हाँ जी, अब खुलेगा। अब लेआउट आप स्क्रीन शो पे कर दीजिए। हाँ जी।
Children less than 14 years constitutes around 44% of population, and there is high mortality in infant, neonatal, and under 5. Over 23 million babies are born in India each year, and over 6 million dies soon after birth. And 2% of babies are born with congenital malformations. Of these, 0.01% have emergency. So there is huge clinical workload of various surgical disorders to be treated in childhood, but insurance cover is less. So there are fewer children hospitals and fewer experts. So many childhood disorders continue to be dealt by adult general surgeons and urologists. As per Kyoto Declaration of the World Federation of Associations of Pediatric Surgeons in 2002, all the newborn, infant, and children deserve to be treated only by experienced and qualified medical personnel. But most seats for training in pediatric surgery are vacant, and most medical colleges don't have a department of pediatric surgery. This makes it difficult for freshly passed pediatric surgeons to enter into academics. And pediatricians trained at centers without a department of pediatric surgery refer patients to general surgeons or allied specialists. And there is no structural referral system or transport facility for sick children, and regional imbalances in training centers. In Bihar, every district having 10 beds of neonatal ICU, but there is no pediatric surgeon in district hospitals. Perhaps this is the scenario everywhere all over country. We can easily imagine how much we lag behind comparing our needs with that facilities. And now present scenario, 111 of 162 seats, approximately 68% of pediatric surgery were vacant in 1920 session. Despite lowering the cutoffs, there were no takers. Despite so many vacant seats, new MCS training centers have been approved, and similar is the situation with DNV seats. So, thoughts of policymakers, there is no thought. Lots of efforts have been made to provide maternal child health care, but not much attention has been paid to the needs of children having deformities needing surgery. They must be realized that by saving life of one child, we are adding at least 50 to 70 years of life. Everyone has his thoughts regarding problems. Politicians or other specialties. People are not right or wrong. They just have a different view of things. So here lies the role of IAPS in sensitizing government institutions, NMC regarding this, and developing dedicated children hospitals and building strong teams. For necessitating the creation of pediatric surgery department in medical colleges, tertiary care centers, and district hospitals, pressure generated by IAPS, then politicians can think about this. Role of UGA may be frame guidelines for setting up of medical institutions for imparting undergraduate courses. मैं जब यहाँ आया तो मैंने सब लोगों से रिक्वेस्ट किया कि आप यहाँ पे अपना रिक्वेस्ट भेजें, अपने सजेशंस भेजें कि MSR जो मेडिकल कॉलेज खुलता है उसमें हम डाल सकें, लेकिन सबके अपने थॉट्स थे, उसके चलते वो डिसीजन हो नहीं पाया। मुझे लगता है कि और प्रेशर जनरेट करने की जरूरत है। टू फैसिलिटेट development and training of faculty members teaching undergraduate courses, facilitate research and international students, ये सारा UGMEB में है, लेकिन उसके लिए प्रेशर और ज्यादा जरूरत है डालने की। हेल्थ बजट हमारा बढ़ा है कोविड के चलते, लेकिन अभी भी हम लोग रेड जोन में है। वर्ल्ड वाइड अगर हम देखेंगे हमारी जो फैसिलिटी है, हमारे जो बजट है, हम लोग रेड जोन में। अब ये जो मेरा जो अभी का जो टॉपिक है कि हम लोग वेदर टू स्पेशलाइज और टू जनरलाइज, तो ये डिफरेंट सब स्पेशलिटीज है। पेडियाट्रिक यूरोलॉजी, सर्जिकल गैस्ट्रोएंटरोलॉजी, न्यूरो सर्जरी, सर्जिकल ऑन्कोलॉजी, पेडियाट्रिक ट्रांसप्लांट सर्जरीज, पेडियाट्रिक थोरेसिक सर्जरी, पेडियाट्रिक कार्डियक सर्जरी, मिनिमल इन्वेसिव रोबोटिक एंड fetal intervention. But when we are struggling to provide basic pediatric surgical care, is it possible to develop subspecialties? Pediatric surgeons differ in their opinions regarding this, but we can develop subspecialties in already functioning good tertiary care centers in big cities. These are some points regarding pro specialization in favor of, for beneficial of, for specific cases, meet consumer demands. This encourages collaboration, good for pooling resources, improving patient outcomes. But opposite thoughts are also there. There are some centers for pediatric urology for fellowship, and multiple centers offer training in minimal access surgery. Developing training in pediatric surgical oncology and renal liver transplantation is also available. Even pediatric cardiothoracic surgeries should be taken up. If you want to be lion, you must train with lions. अपने पास IAPS है, पेसी है, SPU है, एसोसिएशन ऑफ पेडियाट्रिक सर्जिकल ऑन्कोलॉजिस्ट है, एंड रिसर्च सेक्शन जिसमें हम लोग अभी बैठे हैं। और पेडियाट्रिक सर्जरी ग्रो करने के लिए जो प्रैक्टिस में उनके लिए ग्रुप प्रैक्टिस इज वेरी इंपॉर्टेंट टूल फॉर लाइक माइंडेड पेडियाट्रिक सर्जन्स ज्वाइनिंग हैंड्स एंड फॉर्म टीम्स. This decreases the stress and improves the quality of care. And cooperation between institutes for sharing expertise, for exchange of students, and to cross-pollinate to develop the other centers. Other measures are the history of pediatric surgical conditions or oncology cases, outreach program to rural areas, and meticulous data and record keeping, and innovation and research. Some future perspectives like stem cell therapy. Origin and journey of stem cell therapy starts from Alexander Makismo and up to Donald Thomas, who got Nobel Prize in Medicine and Physiology in 1990. Stem cell therapy have viable approach. Mesenchymal stem cell neurotrophic generators to promote functional recovery by angiogenesis, neurogenesis, synaptogenesis, and axonal remodeling. And proximal mechanism for recovery is neurons from transplanted cells relay ascending signal disrupted by injury, demyelinated axons remyelinated by transplanted cells, and paracrine activity releasing trophic factors, this inducing endogenous mechanism of tissue repair and plasticity. This is the article published by the one center from Gujarat. He used this mesenchymal stem cell in spinal cord injury patients. Successful generation and safe transplantation of neuronal differentiated adipose derived mesenchymal stem cells along with hematopoietic stem cell. It is effective therapy in spinal cord injury, not amenable to cure by other modalities. There is no side effect of these stem cells, and recovery can occur even after a long duration of injury. With the development of stem cell therapy, even paralyzed children with neural tube defect can be operated with potential to show neurological improvement in the future. Organ transplant is indispensable for end-stage renal disease in PUV, biliary atresia, short bowel syndrome. Only a few centers in India offer pediatric transplant. So increasing centers and training for pediatric transplants would help to cater the needs of children who are in need of organ transplant. Pediatric cardiac surgery. I thought cardiac surgery is one field where one seldom finds a pediatric surgeon. So if a pediatric surgeon does cardiac surgery for children, results would be better due to better overall management. And minimally invasive surgery or robotic surgery, there is a lot advantages are multiple, and a long list of operations done via laparoscopic surgery or robotic surgeries. Neuroendoscopic surgery for obstructive hydrocephalus has bettered the management of hydrocephalus and prevents complication of VP shunt. Fetal surgery, centers offering fetal surgery and intervention are few in numbers. It would be beneficial to increase the number of centers excelling in fetal intervention to get better results for congenital deformities. Intervention for neural tube defect, PUV, CDH are now possible in utero. There is always a place in space and time for everyone. If we keep our expectations realistic, this branch will reward us a lot. There is a scope. We must dare to dream. The sky is the limit. Thank you. Thank you, everyone, for patience hearing. Thank you.
Thank you, Dr. Vijender. That was very succinctly and point-wise put. I have two questions to you. One aspect was to have the reach of pediatric surgery across the country in all levels of hospitals where there's pediatric medicine. And the other aspect is the new frontiers of pediatric surgery, which you touched upon in fetal, stem cell, cardiac surgery. Which do you think, now that you are also a part of our National Medical Board for UG, which is the more important one? Increasing the reach or coming to the specialization in as far as you are concerned?
दोनों चीज इंपॉर्टेंट है मैडम. मैं जब यहाँ आया साल भर पहले, तो इसलिए मैंने सबसे रिक्वेस्ट किया था कि जहां जहां पेडियाट्रिक्स डिपार्टमेंट हर मेडिकल कॉलेज में जरूरी है, वैसे ही जब पेडियाट्रिक्स डिपार्टमेंट है तो पेडियाट्रिक सर्जरी भी होना चाहिए. अगर लेवल 3 की नर्सरी है तो पेडियाट्रिक सर्जन होने चाहिए. जब हर कॉलेज में पेडियाट्रिक सर्जरी डिपार्टमेंट आ जाएगा तो पेडियाट्रिक सर्जन्स का जो सीट्स अभी खाली हैं एमसीएच के, वो सारे फुल होंगे और लोग डिमांड बढ़ेगा तो स्टूडेंट्स आएंगे. और ये जो मैं बात कर रहा हूँ फ्यूचर प्रोस्पेक्ट्स की, तो सेंटर्स अवेलेबल हैं अपने यहाँ स्टेम सेल थेरेपी के लिए. वहाँ 3 महीने की ट्रेनिंग में कोई भी सेंटर अपने यहाँ स्टेम सेल लैब खोल सकता है. एक टेक्नीशियन और कोई पैथोलॉजी का अगर असिस्टेंट प्रोफेसर 3 महीने के लिए जाता है तो उसके यहाँ स्टेम सेल लैब खोला जा सकता है. और अपने पास हर एक जो पेडियाट्रिक सर्जन है, मुझे लग रहा है कि सबसे अधिक स्पाइनल बाइफिडा केसेस पेडियाट्रिक सर्जन ही करता है, न्यूरो सर्जन से ज्यादा. तो एक बड़ा फील्ड है और बड़ा चैलेंज है कि कोई भी पेशेंट जो स्पाइनल बाइफिडा का है, कुछ ना कुछ उसको न्यूरल प्रॉब्लम रहता है, चाहे सेंसरी, मोटर, कुछ भी हो. तो मुझे लग रहा है कि ये बड़ा जरूरी फील्ड है, उसको मल्टी सेंटर ट्रायल हम लोग शुरू कर सकते हैं.
थैंक यू. हम आपसे शेयर करना चाहेंगे कि डॉक्टर शिल्पा जब आरएमएल में थे हमारे साथ कोलीग, तब उन्होंने स्टेम सेल का प्रयोग किया था पोलियोमाइलाइटिस के पेशेंट्स में. उस समय कोलैबोरेटिंग फैसिलिटी ऑल इंडिया इंस्टीट्यूट दिल्ली की थी और उनके रिजल्ट्स काफी एनकरेजिंग और अच्छे थे. सो जहाँ पे कोलैबोरेशन पॉसिबल है, where it is possible, like same city, you can harvest without even creating the lab. Any question further to ask? Because I asked him which is the focus is important. He said both. Yes, Dr. Sareen, please.
There are two comments that I wish to kind of make. One of them was actually touched yesterday also when Dr. Dhruv Ghosh had given his lecture. Actually, I mean, we have been in touch. Even Dr. Ramadwar is there. He's been in touch with the policymakers in Delhi. And what I understand with the discussions that I've had very recently is that unless we have data and we could say that so many deaths are happening because of congenital abnormalities not being dealt by pediatric surgeons in the periphery, it will not make a dent to the government. So one more thing that which I very pleasantly found out, that the pediatricians, which is a very large body, almost 20,000 pediatricians all over the country, and they're very, very organized. They have now almost convinced the government that in every district hospital of the country, there will be an HDU for children. And so when I talked to Dr. Piyush Gupta, who's supposed to be president of Indian Academy of Pediatrics, what he suggested just a couple of days back is that we should insist that there should be one pediatric surgeon for every HDU, in the district level. As he says, in that case, you will not have to give too much of data, and you will not probably need to start from the scratch all over again. You can piggyback the IAP, and if you could only convince the IAP, he's outgoing president, of course, that they should include this also in their HDU kind of project, then probably pediatric surgeons should soon be getting a lot of jobs in the district hospitals. I thought it was a good idea. And pediatric anesthesia has come up over the years, and a lot of people are now doing those fellowships, etc. Of course, MCH and DM in pediatric anesthesia is available only in very few places. So I think this is the time to hit, and this is the time to kind of get favors from the government, so as we could, actually actualize what we have been thinking and talking about all these many years. Thank you.
Anyone? I think Mr. Ashish Desai has a hand raised. Is there something you would like to ask, sir?
Yes, I thought I will. So just people, the reason I'm butting into this side of it is because shayad half the people know me, other people don't. That I have been a pediatric surgeon. I have practiced for 5 years in Mumbai. So I've gone through my whole training. If anybody asks me in UK where I've been trained, I say I'm trained in Mumbai. So I'm well aware about the Indian setup. And so as Vijayendra said, it is, number one, it is important to have the pediatric surgery being pushed at every center. And just to add to what happens in UK, because you can use that when you're putting these arguments, that we have neonatal units across the country. They have been graded into 1, 2, and 3. And to call yourself as a specialist level 3 neonatal unit, to have being provided in your center. So the people in pediatric surgery in UK is centered around 26 centers, but we go to other centers to provide the. It is important to, like Sarinji said,
I think some audio.
You should have a pediatric surgeon who can support your service. The second thing which I wanted to make about about what does whether you should subspecialize in pediatric surgery. And I think the way practice in Mumbai or India is it is difficult to subspecialize into various areas. But at the same time, within the unit, if you got a unit, especially teaching centers where you got 4 or 5 people, we can easily divide that into upper GI, lower GI, colorectal, thoracic, and urology. And that will improve our results. And that's what my feeling about it is. Thank you.
Well, I thank the people who lied to it, and I hand over to Dr. Shilpa to invite the next speaker and do the rest of the formalities for this particular.
Thank you, ma'am. Dr.
Before that,
Before that, okay.
Before that, we would like to thank Professor Vijendra Kumar. He had a busy schedule, but he conceded to our request to deliver this lecture. So there is a small memento on behalf of Organizing Committee of Research Section of Indian Association of Pediatric Surgeons. Thank you, Professor Vijendra Kumar.
Yes, sir.
We are grateful.
Thank you.
Thank you, sir. Thank you, ma'am. Now we are moving to our next session. The chairperson for the next session are Dr. Ravi Ramador. Everybody knows him. Sir is immediate past president of Indian Association of Pediatric Surgeons. Sir is senior consultant pediatric laparoscopic surgeon. He needs no introduction. The second chairperson for the session is Professor J.K. Mahajan, sir. He is professor at the Department of Pediatric Surgery at PGI Chandigarh. I hand over the proceedings to chairperson for the next session.
Thank you. Dr. Ramadwar, please, would you like to introduce?
Thank you, Vaibhav. Thank you, Professor Mahajan and Shilpa for organizing this. It's a great privilege for me to introduce my close friend, Mr. Ashish Desai. Ashish, I know since 1991, I think. Ashish, is that right? He joined SIGN in 1991. And since then, we have been working together in different parts of the country, in a way. We worked in Mumbai, we worked in Northeast together. We've been in contact with each other for a long time. And we do have informal meetings intermittently. It's my proud privilege to introduce Ashish as a consultant pediatric surgeon at Royal London Hospital in East London. He had recently moved from King's College, where he set up the first pediatric and adolescent bariatric surgery center in the UK and has pioneered bariatric surgery in the UK. His interest has been varied, including minimal access surgery for a long time. He was instrumental in setting up the pediatric laparoscopy training course in Johnson & Johnson Mahim Center when it started for the first time in 1999 and 2000. So he's been associated with teaching activities for a long time, and currently he is the secretary of the British Association of Pediatric Surgeons. So it is really interesting to hear from Ashish what kind of research can be done in clinical scenarios and what innovations are possible. I'm sure everybody is eagerly awaiting to get some pearls of wisdom from you, Ashish. Over to you.
Thanks, Ravi. I started forgetting some of the things like Johnson & Johnson because that was so long ago. I'm not going to give you much of pearls of wisdom. All that I'm going to exonerate is how important it is to have the clinical research networks and how we can work together. Now,
Slideshow.
Where is my slideshow? Let me go in the slideshow.
Yeah, this one. Okay.
So, as pediatric surgeons, as clinicians, we all have certain work. So we work very closely as clinical networks, like how we've all got together here. There are various meetings which we go to, and we network very well. And a lot of times we discuss our cases with each other to see how it can help the improving the patient care. We also do a lot of clinical research, because when you change your technique, or when you're doing, say, hypospadia surgery, and you decide whether you use Vicryl or PDS or which suture material, monocryl, they are all different techniques, and they are all clinical research, because you are changing, you are improving. As far as you keep your data, you see how whether you're improving the patient care or not. We are good at that. We do our clinical research, but where we don't do much better is in the developing the research networks, because when we do certain things, we like to do it on our own and then move forward. We are quite keen on clinical innovations. For example, we do new procedures, as I was mentioning about. And recently, we're like how we do focus technique of doing long gap esophageal atresia management. Or in achalasia cardia, gastroenterologists and upper GI surgeons mainly have started doing POEMs. But we also have developed new techniques like laparoscopic surgeries, and they are all clinical innovations, and it has changed the way we practice, and it has also changed the way we improve the patient care. But when it comes to research, we have been a bit slow on the uptake. The research can be either basic science research, which we have limited resources in India, but it can be either lab-based or on, and then the lab research can be used in clinical scenarios. So, for example, you have genetic studies to decide how the biliary atrasias have been developed, or Hirschsprung disease, or MEN type 2 pathologies. And people have been using stem cell. I believe there was a lecture today about how the stem cell generation has been taking place. And people have been using this in the clinical scenario at various points. But research can also be based on the clinical trial, which is either led by an investigator. So each one of us might be able to set up a research and say, I want to look at how laparoscopic, say, Hirschsprung disease, Soave versus Johannes, whether that has changed the improvement or not. But even newer techniques which we are doing, or we are not thought about. And sometimes these trials are led by the industry or pharma. So they will come to us and say, can you check whether a 3D laparoscopic cholecystectomies are better than a 2D laparoscopic cholecystectomy, something like that. So that is led by the industry, but we can even set up the trials with them. So when they come to you, tell them that we can do that as a trial, because then they can publish. There is a data which is collected. But as I was talking about, we should be developing the research networks. The clinician is the factor in business, because we have the patient trust. So we want to recruit patients. We can develop that patients can trust us. So if we said this is important, this might help, they might listen to you. We have the clinical knowledge, so we can see what is likely to work, what is not likely to work. And we already have established networks. We have clinical networks where we are talking to people. As I said, all the people in this room out here can work together to establish networks to do the studies. And these networks could be either geographic, so it can be either just in the local hospitals, or can be in each state, nationally, or even internationally. And it could either just involve us as pediatric surgeons, or it could be interdisciplinary. Because we can work with pediatricians, we can work with anesthetists, we can work with the adult surgeons or any other field. The benefits of having that clinical research or clinical research network is that you can gather large number of cohort of patients, and you can complete the procedure in less time because you recruit more patients in less time. It prevents repetitions, because what is going on in Patna or in Kolkata may not be known to people sitting in Mumbai or Delhi. And therefore, we all might be doing the same kind of research at the same time. And if running as a network, you prevent repetitions. It also allows you a greater generalization, that if it can work in one population and it works in the second population, then it is likely that it will work in other places as well. You can pool your expertise, because something which I may be very good at and something which you might be very good at, and we can all work together to saying, listen, you are very good at this. Why don't you do this aspect of the study and I'll do the other aspect of the study? And we can pool our resources. As we all know, our resources are very limited, whether that resource is time, money, energy, or infrastructure. And therefore, pooling these resources are very useful. And what it helps us in doing is it improves our research expertise. It increases our research capacity, because initially some of us feel that we don't have the time, or we don't understand, or this research is not for me. But you can at least give your patients in that study as a part of the group. And then the next time something comes up, you say, well, I can do a bit more into this. So you can improve your research capacity. All the research which we do requires funding, and there are various bodies which give us the grant. And if you work as a team, if you've got a larger capacity, you can talk about larger patients, you can get a better finances. And working across the sites helps in improving the regulations, because it is a tedious process. And one of the reasons why we don't like to do research is because the process is so complicated that we feel that it is going to be a waste of time. Each country has a different research regulations. So I'll talk about what is happening in UK. We have a health research authority, which gives the ethical approval. So if I want to set up a study, I need to have an idea. I need to then set up a protocol. And that protocol involves the very detailed plan, saying that this patient will be seen in the clinic. It needs to meet 1, 2, 3, 4 criteria. Once that criteria is done, the patient will be offered the options of joining. So you need to have a patient information literature, which you give it to the patient. The patient then has to sign that consent, and then he will be operated on day 1. He will be seen on day 7, again at 15 days, and then onwards. So you plan that and give that ethical, it needs to have ethical approval. And the HRA will look at all of these various aspects of it. We will be affected by the mental capacity at times, because how do we recruit the smaller children? But it is very common to have pediatric research, and therefore consent from the parents is a valid consent. If it is a drug trial, you involve another body called MHRA. And once they have both approved the process, then you have to go through the individual hospital process. And the benefit of having a network is that if it is accepted in one hospital, PGI Chandigarh, it will be easier to accept in another place. The UK has a National Institute of Health Research, NIHR, and they even propagate clinical research network. So we have another body called UKCRN, which has been funded for 4.8 billion pounds, which is 480 crore pounds. Again, so if you're talking about rupees, it is 100 times more than that. We also have a UK research institution which works across the globe and works with various agencies. And the agency which is in charge with the medical research in India is the Indian Council of Medical Research, ICMR. And they have the people who can train us, they can have the expertise, and they can allow the flexibility in your working. They can also provide you the information and provide you the support. And I'm sure I've gone on ICMR website, there is enough support which they can provide as well. So the important ingredients of having any network is that everybody should be committed to it. They need to understand the various perspectives of every individual has various perspectives, and we need to be clear about how each one is thinking or what is their motivation in being part of that network. We need to be able to trust each other, and right from the start, there has to be a very clear understanding. One of the biggest things which affects internationally is authorship, because we all put in our work, we do that, and then we say, oh, but I didn't get my name on the paper. Oh, I should have been the first author, I should have been the second author, I should have been the main author, which is the last person on the list. And the way it works is that you can decide right from the day one how this is going to decide it. For example, there is a study done in the USA about Teen Lab, which is the teenagers' longitudinal assessment of bariatric surgery. And they have been doing the research for the last 10 years in the same team. And their longitudinal data comes from one center, from one single author as an author. But when it comes to the cardiac outcome of bariatric surgery, it is given by the second author. And when it comes to the renal aspect, it comes from the third author. So there is a very, and time and again, so when they're talking about each of these, there is the authorship guided. So there is no confusion. Nobody can just come out and say, oh, I'm going to write this paper up, because then it breaks the trust and the network cannot work together. We can do this research network even for medical education, because as we have been talking, or I've been listening just now, that people have problems with the various medical education, and what works in one center may not work in the other. So what we can work on is to see how various sites can, how the education delivery in each of the centers, you can decide saying that let's try out something new. And those hypotheses we can interact, or the mediation between the consultants and the trainees can change. And you can then generalize the effect if it works in various parts of the country. And then you can share that research, because if it works in urology, it may work in pediatric surgery. And similarly, so you can use that in medical education as well. But one of the things, again, is to control the network size. A lot of my examples are obesity research, because that's my main area. But we at King's College Hospital, with the adult surgeons, decided that we should have an obesity research network. And we initially thought it will be surgeons. And we will talk to physicians, and maybe we'll have a dietitian involved in that. But then the gastroenterologist came and said, oh, but we do balloons, we can do different kinds of gastroenterology services. And psychologists said, but we want to talk about the impact of psychology into the surgical decisions. And as you can see, different branches started coming in, and the network became completely out of control. And so when you decide, you should start thinking of what that network is going to achieve, and then recruit appropriate personnel into it. And we can use these networks for future innovations and improving patient care. For example, as I said yesterday, you heard about stem cell research, the biomedical basic sciences research, and then the most important in the recent time, the COVID-19 research. And as we can see, around last February 2020, nobody knew even what COVID-19 was. But as soon as it became a pandemic, the international networks were established, which has got huge benefits, because we could get the vaccination done, we could understand what how the symptoms are going to work, and what should be the treatment modalities of that. But as the lessons to learn from that research network is that there could be geopolitical differences. Politics is everywhere, but you should be able to be careful about how that affects the patient care and how it affects your research. And as I talked about before, number of participants should be selective, and so that you can work on that. And the quality control is important, which is very difficult to achieve in the networks. Talking specifically about clinical research in pediatric surgery, when you look at this article, it looks at the number of studies which are being done across the country, and how many of them are randomized controlled trials. And in pediatric surgery, only 2% or less than 2% are randomized controlled trials, and only 10%, so 9.8% in 1998 and 12% in 2013 used a recommended design. Others have been just done on the on the whims or on a planned the person's individual agenda. And that is everywhere in the world. So this I'm talking about international studies. How has UK gone around changing that network perception? So we had upper GI group, so children's upper GI group in British Association of Pediatric Surgeons, which was a clinical group. We used to meet twice a year to discuss complicated patients. And we then decided to do surgery or a decision about long episophageal atrasias. In UK currently, at an average, 1.6 TOFs are done per year by a surgeon. And only 13% of all OAs are long episophageal atrasias. And therefore, if one was to look at their own institutional data, so we have 6 people in our department, we would have very limited number of long episophageal atrasias. And what worked 10 years ago does not work today because the treatments have changed. But by looking at what the long episophageal atrasias across the country is through the CHUGS network, we could approach the clinicians and have a detailed research database, and we could look at the data. Similarly with achalasia cardias, the numbers are very small, and there are 3 different techniques at least: injections, OGD and balloon dilatation, OM, and Heller's cardiomyotomy. And again, in Heller's, whether to do the fundoplication, not to do the fundoplication, whether to do an anterior fundoplication or posterior fundoplication, there are so many different approaches. And therefore, having a network will help in deciding which is the best way to do these things. And these are some other studies which are being done. And these studies have been done by developing an SSL. So what the Royal College of Surgeons came to us around 4 years ago and asked BAPS if we could have a surgical specialty lead. So a surgical specialty lead was appointed who started developing networks and have been able to do various studies. One of the important network which we have is a pediatric trainees research network. So the defect study is a size, they are trying to look at the size of the diaphragmatic hernia and the impact on the patient's survival. And that study is purely done by the trainees, because in every theater, when you're doing a diaphragmatic hernia, either it is done by the trainee or it is done and they are always there. So they would be the one who are driving this. And these networks or the research doesn't need to be very complicated. It could be a simple thing and common thing like appendicitis, and what are the chances of deciding that this right iliac fossa pain is an appendicitis? Or it could be a trauma, which is where the pediatric surgeons are not always involved, but how the trauma is managed before the patient comes into the hospital, and they are doing an observational study on that. Or it could be a multi-specialty network like this study from being done in RCPCH about the type of feeding which we do for NECs. What is the status in low and middle income countries? The ELMIC, there is a global consortium of surgeons which has got a global pediatric surgery network. And they have been using the first one for gastroschisis, and they are looking at the surgical outcomes in sub-Saharan Africa, because the care which is provided there is very difficult because of the same terrains and the financial difficulties. What is the current status in India? I could only find one study called INSEND study, which was to look at the interceptions, and they looked at 40 centers and finally settled with 19 sites after visiting them, and have managed to do a network with 1,500 cases. but that is the only nationwide research network which I could come across. But as Professor Gangopadhyay has written way back in 2013, we need to improve our infrastructure. For the research, we need dedicated time, data collection, and patient retention. So we need to make sure that we can get that. How can we work together? Me, as a pediatric surgeon in Royal London Hospital, or as honorary secretary for BAPS, we can give you the advice about how we manage to get the funding for a specialty lead, so that person, or we can, in India, it might have to be very regional and then a national committee on that. But you could get the funding from, say, National Board of Examinations, like how we got the support from Royal College of Surgeons. I have spoken to Paolo Di Copi, who is a pediatric surgeon, professor in Great Ormond Street, who has been doing a lot of work on stem cell research. And he's happy to get involved with lab-based research. And we could work together on international areas in the low and middle income countries. And there we go. Thank you very much.
Thank you, Ashish. That was a very nice insight into how the networking can be done for research and a productive research, and how various associations and bodies can come together. But the most important thing that remains is that everybody needs to work on this very honestly, very sincerely, and with full transparency, so that there is no confusion of misunderstandings, as well as there is no question that are raised on the validity of the data. And that is where I think we all need to first work as a team. Wonderful presentation. Thank you. I enjoyed it.
Thank you. So you're absolutely right. I think the trust and the data collection is the crunch of it. And we have our own challenges in Indian settings, but I'm sure if there's a will, there's a way.
Thank you for your presentation. That was giving excellent insight into how to carry out research and what are the problems faced. Paperwork is one of the factors which really put you off. So do you have any ideas like how to overcome that? Because whenever you are writing a project or submitting some proposal, as you also said that paperwork, extensive paperwork and regulations one has to go through is a real dampener. So what are your suggestions on that?
So I think the problems which we face about data and putting that data in the proper format is a problem. So when you are putting that fund grant, looking for the funds, it is important to have a short time for your secretaries to put that data on. So either a nurse or a secretary or a trainee, but you cost for that, so that you can say that maybe 1 hour a day we will be putting the data on, and that 1 hour a day is going to cost us 1,000 rupees per day or something like that. So you put in that data, you put in that number and ask for that funding. So you have the funding, then you can employ a person, because if you're doing 4 or 5 studies at the same time, you will have a person doing that half the time of your day. So that is a way to get incorporated into that.
Dr. Shilpa has a question.
Thank you for your excellent talk. I would like you to throw some light on audits. Whereas in India, most of the studies are observational based, retrospective work. When I wanted to do an audit in NHS, they asked me, why do you want to do an audit? Was there a complaint or something? So can you throw some lights on audit?
I think I don't know when, so anything which we do in NHS, because it involves time, and therefore the time is So I don't, it means I do a lot of things free, but we get funded for it. We get a time allocated for it. They want to know why you're doing something. So the quality improvement is a very important aspect of the care. And therefore, we have a regular quality improvement projects going on. And every 6 months, we have the whole hospital wide, we have a quality improvement day where we'll talk about what projects, so people will present their projects, and then we'll decide what is the, so they will present their quality product. So once you are doing that, you are incorporating the culture of quality improvement. And that helps when you're doing when you're setting up the new studies. So similarly, for whether it is audit or whether it is research, it will help in setting that up.
So that is where we are lacking in
India. That answers the question.
Yeah, that answers my question, but that is where we are lacking in India. We don't have an objective as quality improvement. That is the main crux here.
Shilpa, audit actually forms the basis for any research. So you have to have audit with the data to be projected, and then you can project your own thesis of why you want to do a research on a particular area. So unless you have a basic data of auditing various numbers, various issues with the problem which you are thinking of researching, there is no basis to start a research. So audit would remain the mother of all researches. And that is something which is completely lacking, unfortunately.
Yeah, but I think the important thing is so what you realize when you're sitting is that there are people in UK who have a very long-term data of their Hirschsprung disease. So they will know every time the patient comes, there's a chart given to them and say, can you put your quality of life projects? How many times do you stool? How many times? So it is a written document which can be done while the patient is waiting to come and see you inside. So he gets that form, he ticks that boxes, and you get it in. And therefore, then once you have that form, it is very easy for you to see how your SOAVs are doing. And once you know what your SOAVs are doing, you know whether it needs to be changed or not. So that sets your research. So what Ravi was talking about is you have an audit, so you know what needs to improve. And once you know what needs to improve, then you work on it to improve that and do the research. So, and I think it is being aware that doing this research or doing this audit is going to help you because it helps your patient. And then it can work.
Thank you so much.
Good. Are there any other questions from the audience?
But thank you very much, Dr. Mahajan, Dr. Shilpa, and the whole team. Thanks a lot.
So thank you very much, Mr. Ashish, for your presentation. There is a small token of gratitude from Organizing Committee of the Research Section of Indian Association of Pediatric Surgeons. Thank you for joining us.
Thank you.
So this brings us to the end of the first session. Now I'd like to hand over the proceedings to Dr. Shilpa for next session.
I would now like to invite Professor Simi Ratan. She is the professor and head of Department of Pediatric Surgery at Maulana Azad Medical College. Professor Simi, please, for the next session.
Thank you. First of all, I give my gratitude to the main organizers. Obviously, I am also one of them, but to Dr. Shilpa as well as Dr. Mahajan to organize such a nice program. And we have a very wonderful session, which we are heading for. This is on innovations in pediatric surgery. And to chair this, the first talk of the session, I would request Dr. Ramesh Babu, who is a professor and senior consultant in pediatric urology at Sri Ramchandra Institute of Higher Education and Research, Chennai. and he has been a past chairman of Society of Pediatric Urology, IAPS. Then chairperson is Mahajan. He is the senior professor at HOD Pediatric Surgery at SN Medical College. And our third chairperson is Dr. Rajendra Gritlare. He is the consultant of pediatric surgery at Gandhi Medical College, Bhopal. So I would request the chairperson to join in and introduce our speaker.
Thank you, Dr. Simi. Can you hear me?
Yes.
Yes.
Yeah, it's a pleasure to introduce Dr. Sagar Chawle. He's a pediatric surgeon who has actually turned into a scientist. And he has more than 100 inventions till date, and he's got 40 patents registered in Mumbai office. And 25 of his inventions are reported for the first time in the history of medical sciences. And he has developed 17 new operations, 13 new therapies, and many of his inventions are 20 to 50 times cheaper than the peers, which is a great boon to the mankind. So without much delaying, I may hand over the mic to Dr. Sagar. Thank you.
Okay. Can you see my screen, please?
Yes.
Yes. The honorable chairpersons and my friends, today's topic is my innovations for pediatric surgery. Yes, okay. Most of the advanced therapies in medical devices in pediatric surgery are not affordable to the pediatric surgeons and the patients. And then what is happening is they are practicing without it, which is, I think, the worst thing that can happen. And to bring this dream into reality, I did my own research and developed all these innovations, which are more than 100, but 30 which are relevant to pediatric surgery will only be presented here. This is the new institute which is owned by me, where I do all this research work and my clinical practice. The project received 10 international and 10 national awards. The first is flexible video laparoscope, which is flexible in 5 and 8 millimeter size. It is flexible at all the points with a video camera and 6 LEDs fitted at the tip of it. And basically, I designed this for single incision laparoscopic surgery, where the instruments tussle between each other. This laparoscope can be bent at 90 degrees at the port, and the vision is not disturbed at all. That is the basic purpose. It is commercialized only in 20,000 rupees. I have done more than 200 operations with it, and it is easily worth 5 lakh rupees and published in a journal called Tropical Doctor. This is the detailed view. You can see the number 6, the white tube is totally flexible, and the camera at the tip with LEDs, and it has a USB output that fits right from mobile phone to all sorts of Android devices, desktop, laptop, everything. The same flexible video endoscope is used in anesthesiology, coupled to a laryngoscope becomes a video laryngoscope, and can apply to all sorts of blades, can put inside an endotracheal tube to see the glottis plus the trachea, and is superior to the video laryngoscope from that respect. Can be put into the endobronchial tube and guide into the bronchus for single lung anesthesia. Otherwise, you need a 10 lakh rupee image intensifier for that, which is not affordable, neither it is portable. To put inside endobronchial tube to check for any blocks, to put inside tracheostomy tube to check any block, and as a diagnostic bronchoscope. The same one made a bit thinner, 4 millimeters with 4 LEDs, can be used for same purpose as a pediatric or neonatal laryngoscope and for pediatric anesthesia. A proper video laryngoscope in just 20,000 rupees. You can see photo 3, the phenomenal image quality. The camera with LEDs have been coupled to the laryngoscope blade. Now all these devices are unique and they are all reported for the first time in the medical literature. And similarly, a rigid video laparoscope, 5, 8 and 10 millimeter, where the photo 2 shows you the mastic-like cameras with LEDs fitted at the tip. Photo 3 is the phenomenal image quality, published in Journal of Minimal Invasive Surgery, cost only 20,000 rupees and easily worth 6 lakh rupees No endo camera is necessary, no LED light source is necessary for that. Photo 3 is the phenomenal image quality you can get with it. This is the commercialized version of rigid video laparoscope costing 20,000 rupees. Similarly, an articulating video laparoscope, it can get, as you can see in photo 2, turn down 180 degrees, can show as well as rotate 180 degrees. So it can show any corner of the abdomen, which is not possible with any laparoscope in the world available today. And this was made in 50,000 rupees. Olympus has the same in 10 lakh rupees. Now, dual vision video laparoscope is the first of its kind in the medical literature. It has two cameras, one 90 degree and one 0 degree, commercialized in rupees 50,000. No peers available for the comparison. The 90 degree camera can show retrocecal areas, the hiatus, the pelvic cavity, above the liver, and all the and the side of the maybe the in cholecystectomy, the side view of the Kalos triangle, and the gastroscope, colonoscope, sigmoidoscope, bronchoscope, etc. were bought on eBay, which was scrap. And a 5,000 rupee camera with LEDs were fit at the tip, and they were made functional. And each of them cost 15 lakh rupees actually. And 25,000 rupees they were made functional, and the same benefit was given to the poor patients. A rigid video sigmoidoscope, you all know, are just tubes which are poking into the patient's body. Last 100 years, there has been no advance in it. Till I made a rigid video sigmoidoscope, again reported for the first time in the medical literature. It has video camera with LEDs at the tip, with an instrumentation channel, a USB output, a gas port, and an instrumentation port, which is 9. Now, the beauty of the instrument is that it can accommodate through its instrumentation channel all sorts of laparoscopy instrument you already have. Now that makes it very powerful diagnostic and operating machine, which can be used in pediatric surgery for Hirschsprung biopsies, polypectomies, coagulation of rectal ulcer, banding piles, etc. Commercialized only in rupees 40,000. On similar grounds, a rigid video esophagoscope, which is 8 millimeter in diameter, LEDs and video cameras fitted at the tip, with a ventilation channel and an instrumentation channel of 2.5 millimeter, which accommodates 2 millimeter instruments, commercialized in rupees 40,000. In pediatric surgery, we use for removal of foreign body esophagus and for esophageal stricture dilatations. Now, for removing foreign body without this kind of a device, you need image intensifier usually, which is 10 lakh rupees investment, which pediatric surgeon has to unnecessarily do. And you can get away with that with the device. A video gastroscope and a colonoscope, 2 mm instrumentation channel, 8 millimeter outer diameter. This body can move 180 degrees. That is how it is superior to Olympus and stores. And commercialized only for rupees 75,000 instead of 15 lakh. This is another unique device reported for the first time in the medical literature, a beautiful merger of a retractor, a video camera, and a LED light source in the form of LEDs, which can be put through the umbilicus. I developed for minimally invasive open surgery, where poor patients cannot afford laparoscopy, and through a very small incision, variety of open surgeries can be done. In a very small incision like laparoscopy, the surgeries such as transumbilical, appendicectomy, polypectomy, tubal ligation, tracheoesophageal surgery, VATS, and open pyelolithotomy, pyeloplasty operations, costing only 20,000 rupees. A rigid video bronchoscope is amongst the most complex devices I have created. It is a 5-in-1 device where the forceps, the sheath, the ventilation channel, the camera, the LED, and the ventilation, and everything combined in a single instrument. Outer diameter of only 5 millimeter, and has a ventilation channel, and can remove the foreign bodies. And again reported for the first time in the medical literature. It was a commercial hit with more than 25 pieces sold in India and outside, and commercialized for 40,000 rupees, published in International Journal of Otolaryngology. Now, the kind of grip and precise control it gives at the tip is not possible even with flexible instruments. So people might think your flexible bronchoscopy means the best for foreign body removal is not true. For removal of foreign bodies, the gold standard is rigid instruments, and I have made it even better. So this is best of the best possible for removal of foreign body. A rigid video bronchoscope without forceps with an instrumentation channel for medical bronchoscopy, costing only 30,000 rupees. A rigid video neuroscope. Somebody just talk about ventricular surgery. The equipment is 7.5 lakh rupees. Who is going to afford that? This is just 30,000 rupees and superior than that because that is rod lens. Mine is a video endoscope, costing only 30,000 rupees. You can do the third ventriculostomy operation with this. A wireless endoscopy, the world is yet to hear about it, and we have ready in India in just rupees 10,000, a matchbox-like device that fits to the back of all my previously described endoscope USB output, and they all become wireless. So we have wireless bronchoscopy, wireless laparoscopy, wireless hysteroscopy, and whatnot. And just in rupees 10,000 with a battery backup of 2 hours. This is also reported for the first time in medical literature. The wires are extremely annoying in the operating field. That is why this device is of great value. A laparoscopic endo camera usually costs 3 lakh rupees. I have developed in 30,000 rupees, which is 5 megapixel video resolution. Starts and Olympus is just 1 and 2 megapixel. The mother of that camera, the highest resolution in the world, 34 megapixel, costing only 50,000 rupees. As I told you, Starts Olympus is only 2 megapixel, selling from 3 lakh rupees, 7 lakh rupees, 10 lakh rupees. This is massive 34 megapixel, and I'm proud to say is the world's highest resolution anybody has ever imagined. Oxygen in insufflation gas and laparoscopy, according to me, is one more very basic advance done by me. I did 758 cases of laparoscopy with oxygen as an insufflation gas in last 10 years. The right video showing oxygen, 100% oxygen and cautery use. Oxygen is a medium and does not burn by itself. It's not a fuel like hydrogen. So no explosions will happen. That is absolutely ignorance. Carbon dioxide is a poison to the human body. And that is why there are sudden and unexplained deaths, which nobody talks about. It is inhuman. Patient dying in appendix. I have seen patients dying in appendicectomy, in laparoscopy, in orchidopexis. It is absolutely shameful. That happens due to the hypercarbia. Another thing is using cautery in 100% carbon dioxide and zero oxygen environment is very unscientific. Produces a lethal gas called carbon monoxide, which I proved by doing it in a jar with a carbon monoxide meter. So carbon monoxide, a potentially dangerous gas produced, carbon dioxide leading to hypercarbia, all is now preventable by using oxygen as an insufficient gas. This is under publication with an international journal. A semi-flexible thin video nephroscope of the diameter of 5 millimeters is again reported for the first time in the literature, costing 40,000 rupees. I developed for PCNL as well as for open stone surgery, where after removing the stone, if you have to see fragments inside, use an image intensifier costing 10 lakh rupees, and it still does not show many fragments. And you miss a fragment, that may be considered a negligence, and a redo surgery. Nowadays, you can imagine how much of a trouble. All can be saved to a surgeon just with a 40,000 rupee device. A rigid video cystoscope, again a first device of its kind in the medical literature, it has a straight channel, can remove bladder stones with a lithoclast, with a laser fiber. Lithotripsy can be done, can do suprapubic work, can be used for PCNL. Here I have fitted the camera in the sheath itself, so no separate telescope, direct USB output, and some 24 French outer diameter is a bit thicker. So can be used in adult and selective pediatric, but I am making a thinner version of that also. Commercialized in 40,000 rupees. Similarly, a nephroscope was just 10 French in diameter and 50,000 rupees was made. Almost similar device, but thinner. A urodynamic has great value, but since pediatric surgeons cannot afford the 30 lakh rupee machine, most of them practicing without that. which is the worst thing that can happen to the patient. So I made my own machine, and the urodynamic catheter's output was given to a multi-channel digital pressure transducers, and through the data acquisition device given to the computer, and the software was made under LabVIEW platform. The whole thing can be commercialized in 75,000 rupees instead of 30 lakh rupees. This device is capable of showing you all 7 and 8 parameters: bladder pressure, destructive pressure, this, that, all sorts of things, what a big machine can show. Similarly, a uroflowmetry machine in 30,000 rupees. Stem cell laboratory is designed only in 30,000 rupees instead of 30 lakh rupees. And that is why the autologous stem cell transplantation can be done just in 70,000 rupees in my hospital instead of 5 lakh rupees in India. And because of that, I could do the world's first intrapancreatic stem cell therapy for type 1 diabetes. And this omental cell pouch operation, which is reported for the first time in medical literature for type 1 diabetes. Tumor treating fields for cancer is USFDA approved for brain tumors. The left photo 1 is the device costing 2 crore rupees. And it is rented, so 3 years means 6 crore rupees. What it creates is a strong negative field around the cancer, so that the cancer cells cannot divide, because cancer cells create negative field inside the cell to distribute the genetic material. When the outside field is stronger than that, the inside field cannot develop and the cancer cell dies. This is FDA approved, studied under electron microscope. I modified this machine where now the electric field is created in the blood and the tissues with the electrodes shown in photo 2. And now the beauty of it is that all types of cancers can be treated with this kind of a device. It is currently under trial. It's my very recent invention, and costing only 15,000 rupees to be permanently given to the patient. And if this is successful, the radiation, surgery and chemotherapy, all three for cancer, are going to get outdated. A capsule endoscopy device, you all know the capsule we swallow, costing 3 lakh rupees, was made in 10,000 rupees. Now, nobody in the entire world could make this out of Japan. This was developed in India. I think should be a proud moment for all of us. The photo 2 are the components. I have given demonstration of this in IAPS conference. A laser lithotripter is a 20-watt Nd:YAG laser machine with a detachable optical fiber of just 1 millimeter, which can go through the channels of the various endoscope, rigid and flexible, breaking bladder, ureteric and kidney stones, made in just 30,000 rupees instead of 40 to 50 lakh rupees in the market. This is published in Global Journal of Research. And the same machine can be used as a laser cutter in open surgery, photo 1, by adding a laser guide. Photo 2 in laparoscopic surgery, by putting the fiber through this guide. Now the world does not have a laser cautery of this kind in open and laparoscopy surgery. And before the world has, we have this kind of a marvel developed. The beauty of laser cautery is that laser cautery photocoagulation is much better than electrocautery, and the bleeding that does not stop with electrocautery stops with laser. That is the beauty, and it is far less destructive to the tissues around. Laser tissue welding is a technique I developed where 40% albumin put in tissues and a laser of 5 watt fired over it leads to a watertight bond, and healing of 2 weeks happens in just 2 minutes. A nice 10 lakh rupee machine is used for this purpose, which I developed in just 7.5 thousand rupees. And the tissues were spleen, liver, pancreas, brain, kidneys, where sutures don't hold. This is the indication for the techniques where the bleeding can stop, which does not stop with the conventional cautery. Similarly, glutathione albumin glue induced tissue welding for circumcisions, ALW sutures, bowel perforations, anastomosis, etc. The cost is only 50 rupees. The non-invasive vagal stimulation device is very important. I developed this machine in 10,000 rupees for the purpose of treating post-operative paralytic ileus and constipation. It is already FDA approved for epilepsy. And it's an invasive 20 lakh rupee operation. And now it can be done in non-invasive manner and solves a very big problem in pediatric surgery, which is paralytic ileus and constipation. This I developed for COVID and for URTI, and 254 nanometer ultraviolet LED, which can be put into the pharynx and the nose and kills the COVID organism in the nasopharynx. within seconds, and no resistance is possible to ultraviolet by any microorganism. This was developed in just 10,000 rupees. It's again reported for the first time in the medical literature. There is something called ultraviolet blood illumination, where the blood of the patient is to be taken out. 10-15% volume is exposed to ultraviolet light. Then it leads to strong stimulation of the immune system. And when the whole blood volume is exposed, leads to strong inhibition. I wanted to bring this marvel to pediatric surgery because such a thing cannot be done in neonates and infants. So I designed this instrument where the ultraviolet tube is put into the rectum of the child after an enema, just for 5 minutes, exposes 15% of the blood volume, leads to severe immune stimulation. We did a local trial, and where patients were on meropenem and not working, and the C-reactive proteins were 80 and 100, came down to 8 and 10 normal range just in 48 to 72 hours. This is going to be a major breakthrough in treating various pediatric and neonatal infections. You do a great surgery, but the child dies of sepsis. Now that may not happen due to this device. The same modification of the device for treating vaginal infections. An intravenous variety of the same device for treatment to the adults. Lipotron therapy device I developed in 10,000 rupees, which pumps electrons through a ECG electrodes into the peripheral vein inside the body. My research is that the electrons act as antioxidants, but what is more important, that the therapy stimulates the vagus nerve, and the vagus is important for stress management. I believe that every ICU patient, this device should be applied, because the patient, what I have observed is the pulse of 250, 270, despite hydration and everything, due to the stress and inflammation. There is no way to bring it down. By putting the device, it comes down within 1 to 2 hours in the range of 120 and 150. Even the respiratory rate comes down because the vagal stimulation, and the tachycardia as a symptom itself can kill. So basically it prepares the patient for the stress. Otherwise, the vagus is not proportionately stimulated and patient succumbs to it. But I think this is a whole big lecture, so I stop there. IV imaging system, you know, is a very basic device, but we did not have in India, so I developed in 5,000 rupees. So, we have a larger muscle stimulator, but I developed a portable one in 10,000 rupees because the wires are annoying in the operating field for the Pena's operation, again reported for the first time in the medical literature. LED light cord, a small invention, but reported first time in the medical literature. LED itself put at the tip of the endoscope, so no LED light source and no fiber optic cable, costing only 10,000 rupees instead of 1.5 lakh. And these are my future innovations. Hands-free robotic camera holder, Da Vinci Robo, cochlear implant, artificial urethral sphincter, a laser microscope, tissue nanotransfection, etc., portable MRI, SWL. And thank you very much. And a big thanks to Dr. Shilpa Sharma Madam and Dr. Mahajan, who gave me this chance of speaking here, gave me a slot in the middle of such esteemed national and international speakers. That is the proof of their honesty. Otherwise, such things usually do not happen. Thank you very much.
Thank you, Sagar. It was a very nice and wonderful lecture. May I start with some questions?
Yes, sir.
I have 3 questions. I'll go one by one.
Yes.
How do you get ideas, money, and manpower for your various research projects and ideas?
Ideas are certainly my own brain, and manpower and money is also my own. I was absolutely given no help from anybody, and neither did I ask for it. And I know that in India, not a penny is given for research by the government and even by the private companies.
Okay. And what are the challenges you face in getting approvals, patents, and ethical clearance for various trials which you do with your new innovations?
One good favor that Indian government has done is that the biomedical devices are deregulated, so they do not require any approval currently. Only implants are regulated by the FDA. So any device, if I make, if it is US FDA approved, then that is perfectly legal. I have a registered company, I can start selling that. The second is patent, means you have to fight at your own, you have to fill up, and they take 10 years to give you patent. That is not in your hands. But once registered, that is valid till it is rejected or till it is given. So patents give you protection so that nobody can copy that. Money you have to spend yourself, and I am selling, getting some money from that, and that is funding the project, but absolutely no external help of any kind.
And my third question is, what are the marketing challenges? How do you ensure that your innovations reach the target population? For example, your aerodynamic machine is pretty much, cheap and then very good. I mean, I didn't know it. I would have bought it. So, like, how do you ensure that it reaches the right target population?
Now, since the innovations are given almost cost to cost, because this is a no-profit organization, I cannot afford the commercial ways of propaganda and etc., which is very costly. So I post in the Facebook and Twitter and whatever, and to the various organizations, and from that I get very few orders, if at all. That is the only source, and otherwise there is no source to me. I cannot afford the kind of costly advertisements available which other companies are doing, and then looting the patient, looting the doctors in return for that is out of my, does not fit into my ethics, first of all. So whatever little activity is going on, that is enough for me. More than 100 innovations have been sold of different kinds in last 3 years, which is not a very big number, but not a small number also.
Sir, there is a lot of cost difference between your innovations and marketed equipments. So because they use different type of chips and these cameras, the material they use, is there any different type of material or anything else you are using?
No, it is, the material is not manufactured by me. It is manufactured by the Fortune 500 companies only. So that is the message I want to give. My research product exposes the greed of the pharmaceutical company and the medical device companies. It exposes how they are looting the patient. I told you that the cancer device costing 2 crore rupees per year. So generally you need to use for 3 years, 5 to 6 crore rupees is made only in 15,000 rupees. Stem cell therapy, which is charged 5 lakh rupees, is only costing 50,000 rupees at my clinic. So my research throws light on the real cost of the equipment and the therapies, and how much the corporations are looting. But government should take it on their agenda. And from government side, I got absolutely no recognition and no appreciation and no help at all. That is the tragedy.
Thank you.
Sir, one thing more that
could we? We are running short of time.
No, Dr. Simi, we can allow question from
one question. Okay, because the time said 3:15. It's already 3:30.
Oh, this is not a question. It is a humble request, Dr. Jawale, that you should give some advertisement on quality. Because as far as this one example is that this aerodynamic machine, definitely there is a lot of cost difference. And most of the time the government sectors have a cost difference that we can't purchase these machines. So if you can market these specifications and then they can purchase at this low cost and it can be used. So marketing is a must. This is my humble request.
No, in the institutions, in the government particularly, and even in private, it's a open secret that they want commissions. Now, why should I give, and from where should I give the commissions? And why would the government institute buy my products? And what is the point advertising and approaching them?
Not to approach, sir, just only marketing. The persons who need it will read it.
May I just butt in once? May I please just butt in one? Dr. Sagar, I am really amazed by your work. It's really commendable. Please send us an advertisement of your various products, and we will publish it free of cost in Journal of Indian Association of Pediatric Surgeons. At least 2,000 pediatric surgeons will come to know about it. Please do it. You
Okay,
can
sir,
send
but
it.
my articles have been rejected by the Indian Journal of Pediatric Surgery also.
Sir, that is an anecdote. Please don't talk about it. What you have done, we are ready to support you. You said nobody
Okay,
supports
sir.
you. We are ready to support you. Just send an advertisement, and the paper that has been rejected, please rewrite and send it back to me. I personally will see that what can be done about that paper. That's a word from my side.
Okay,
If you
thank you very
please
much.
cooperate with us, we will be growing together.
Yes, sir. I'm very much ready for all sorts of options.
Yes, please, and do it in 7 days' time.
Yes, sir. Maybe today itself I am.
Okay, thank you very much.
Thank you, sir.
We thank all the chairpersons as well as Dr. Sagar for such a wonderful deliberation that he has given. And we had good, fruitful talks after that. I'm sure your innovations will find more place to be, utilized. And we will also like to be one of the fruitful user of that. For that, I had in fact written how we can procure it. And I think we all are interested to make use of your so effective and so cost-effective also innovations. Thank you very much. Now we will go to the next session, for which there are. I would like to invite Professor
Dr. Simi, just 2 seconds to us. So thank you, Dr. Jawale, on behalf of all of us here.
Thank you very much, sir.
So this is small token of appreciation. Great work.
Thank you, sir. Thank you very much.
Thank you. Yeah, Dr. Simi, you can carry on.
Yes. Professor Ashok Kumar Basu, I think he was just now here to encourage Dr. Sagar that for all the research that he has put in, all the innovative point he has applied. He's Professor Ashok Kumar Basu is a consultant at Institute of Child Health, and he's editor-in-chief, Journal of Indian Association of Pediatric Surgeons. And sir, we are really proud of the way the journal is doing, and it is held to be one of the most coveted journals among the fraternity of pediatric surgeons. And then second chairperson is Dr. Santosh B. Corbett. He is a professor and head, Department of Pediatric Surgery, JN Medical College, Tahir, Belgaum. So over to the chairpersons to introduce our next speaker, who will also be talking about innovations.
Thank you very much. Dr. Vikesh Sagar, may I also greet the co-chairperson? I cannot see him.
Dr. Santosh, please switch on your video.
Okay, Dr. Santosh and Vikesh. I know Vikesh for a very long time. He is a very good pediatric surgeon, and he is also the son-in-law of a very good friend of mine from Jabalpur, where we had a very nice conference. And he has grown into a very good laparoscopic surgeon also, and he is a teacher and member of many of the societies. So without wasting any more time, may I request you to present your paper, please?
May I request the operator to allow me sharing, please? While I heartily thank Dr. Sharma and Dr. Mahajan for giving me this opportunity. Am I allowed to share?
Yes, you are allowed. IT,
audible. You're audible.
IT, please allow sharing. Mahajan, sir.
Yeah. Can you please, you can see my screen?
It has just started. It has started sharing, but not yet visible. The slide is not yet visible.
Not getting the bandwidth.
Yeah. Is it there?
Not yet. You can switch off your video and then try. Maybe it comes faster.
Dr. Vaikesh, you can close and start sharing again.
Yes, forward.
Shall I introduce, sir? Shall I read his CV?
Dr. Santosh, it's already done.
Shall I read the CV of Vaikesh, sir?
No, it is already done. You were a little late. It's already done. It's already done by Professor Basu. You can ask the questions later on.
In fact, the topic that Dr. Vaikesh has to be covered is very much relevant to Indian settings. So we are just waiting here. I hope he's going to share it soon.
Yeah, Vaikesh, all well?
Yeah, all is well. I think it got disconnected for a moment.
Yes,
doesn't matter.
Now we can see your slides. You can go.
Yeah, we can see your slide.
10-minute presentation. Hope this internet stuff helps me out here. Yeah.
Don't worry.
Okay, fine. After a very fascinating talk by Dr. Javale, and his hard work is unmatched. And what I'm going to share here is being in a very modest institution with limited resources when I joined 16 years back, and gradually we scaled up our work and advanced our work in the field of pediatric surgery. We had certain ideas in our mind, which came basically, they were beyond science of surgery. We all know, we have appreciated in the last 2 days how the science is important in research. But art of surgery is something which comes from knowledge, like you modify on the basis of your knowledge, devise new techniques, you come across certain ideas, and the solution which you come up with leads to innovation. So that is what it's all about. One approach which I personally adopt in my clinical work and research is the prismatic approach. This is one editorial we published recently for a younger generation, where many people ask that what type of research you should do in resource constrained settings, like how to create more publications, how to share your experience with others. So
your slides are not moving. We are still stuck on the first slide. So you can go to slideshow and move.
Can you see my third slide now?
Yes, we can.
But slideshow is not working. That's okay. I mean, I can avoid.
That's fine.
So this is the prismatic approach, where we basically divide into 5 categories. One is pragmatism, that is to come across a problem. You should not despair and give up. You should try to find solutions, and that leads to certain observations in the form of epidemiological or observational study or an outcome assessment study. Then the second part is research. Research, I don't mean research. Research is like something is already available in the Western literature, but it may not be suitable for your own particular setting. So you can conduct sort of practice gap study or prospective intervention study using new modalities. The third is innovation. Like Dr. Javale talked about low-cost solutions in the form of low-cost instruments. There are certain low-cost or local surgical technical refinement, where you basically modify or repurpose an operation. or you can devise new approach to a disease. Then we have a lot of like level one evidence available, but at times it is not applicable to the resource constrained settings, and you need to scrutinize the evidence, which may be conducted in the form of review, systematic reviews, meta-analysis. And finally, you should measure where you basically measure your work, your outcome, and you come across various prognostic scores, decision-making algorithm. So in 10 minutes, I would like to just share a few of my experience based on this approach. One thing is like we commonly come across anorectal malformation. We do a lot of anorectal malformation surgery. The standard colostomy is the left iliac fossa colostomy. As we nowadays routinely do only laparoscopic pull-through for high anorectal malformation. So just with the simple idea of lateralizing the colostomy into the flank, the ergonomics of the laparoscopic surgery becomes very easy. Because you see in the picture that baseball diamond concept is retained in a lateralized colostomy. This work is published recently. There are certain category of patients where we have started doing one-stage surgery in neonatal anorectal malformations. And the biggest challenge is distended abdomen, distended bowel, which doesn't allow much space to work inside the abdomen. There was a video here, but as slideshow is not working, I'll just narrate it. It's a transperineal intracath meconial and evacuation technique, where what we do is we put an intracath through the perineum. As the rectum is very dilated, it usually goes into the rectum. We may use at times ultrasound guidance also. And once that intracath, 16 French intracath goes into the dilated rectum from below in the perineum, we deflate the rectum from there. And after that, the rectum becomes totally empty. There's a lot of space in the abdomen. You can give rectal wash through that intracath to create the space, and you can do a primary laparoscopic anorectoplasty. Now, similarly, like hydronephrosis, though we get a lot of antenatally detected hydronephrosis too, but still in our setup, we get a lot of giant hydronephrosis. And here we have devised an approach where if you see that PUJ lies just below the umbilicus. So we apply the Bianchi technique in selected cases with giant hydronephrosis, and with the small umbilical incision, easily with a stay suture, once you empty the pelvis, that PUJ delivers out easily. Even with this incision, you can see that calyces are seen. You can do a very good pyeloplasty, excision of the redundant pelvis with a DJ stent here, and very small single incision. So initially, we used to do it laparoscopically, decompress, take it out and do it. But now we have straight away changed the policy to transumbilical pyeloplasty in selected cases. Similarly, hiatus cyst, the size which we come across, about 40-50% of patients, they are like huge size cyst. And here there are certain challenges with laparoscopic approach where you have to basically, there's a lot of spillage and incomplete evacuation because of large amount of laminated membrane. So what we devise is like a small incision, single incision trocar-less endoscopic surgery. You need not have any special trocar. With a controlled stay sutures, we deliver the cyst, sanitize the cyst, deliver all the content. And after that, we put endoscope inside. By the side of the endoscope, we put a suction cannula and evacuate all the cysts present inside. There was a video here, which I'm not going to run. Similarly, there is a challenge here in the pediatric stone disease in two forms. Like in our department per se, we don't have PCNL and URS facilities. And secondly, the stone size is very large. So these patients eventually used to land up in open surgery. So now we started doing like laparoscopic parallelothotomy, ureterolithotomy, especially for bigger stones. Nowadays, there is a super specialty hospital where a lot of endoscopic surgery is done. So we send few selected patients to them as well. Coming to another problem you encounter in our scenarios like empymas. They come to us very, very late at times. And they are not very suitable for VAT surgery. They are suitable for only open surgery. And the peel is like very, very thick, and it's not so easy to remove it endoscopically. So they'll end up in open decortication. So we devised a simplified thoracoscopic extrapleural approach. I heard someone saying about this. If I remember correctly, Professor K.K. Verma or someone who use a similar sort of technique where we don't open the parietal pleura first. After opening the chest, we dissect the parietal pleura from top to bottom, and that basically helps to remove the peel en masse, like two halves of the coconut. After you have excised the parietal pleura, then you can do the visceral pleurectomy, and you can achieve the lung expansion. As we all know, necessity is the mother of invention. In few of the cases, as we don't have a cholangioscope with us, with choledochal cyst, we encountered intrahepatic stones. As we all know, these stones are usually soft, and we use pediatric cystoscope to remove these stones. And this technique is followed by few Japanese people also. But we were happy to use this in 4 or 5 cases, and it works well. At times, special instruments like pyloric spreader or pyloric knife is not easily available to you in resource-constrained settings. So here we devised a technique, hybrid technique. This video I'll show after the presentation if the organizers allow, where we put only one working instrument. We take the pylorus near the abdominal wall, and percutaneously we put a blade and incise the pylorus and open the pyloromyotomy, do the pyloromyotomy with the usual hemostats. So what we understand or we follow as surgery is a philosophy, and it's not a religion. At times there is a need to deviate depending on the geographical situations or the conditions in which you are working. This is one of the example where early laparoscopic management of appendicular mass is being done, where usually Usher-Shannon regime is the policy, because there is very high rate of complication in conservative management, especially when there is a missed perforation inside or a gangrenous or sloughed out appendix. Based on our experience of huge experience of pediatric empyema for almost 10 years, we devised a Jabalpur image-based staging system, which is an objective system where we use ultrasound and selectively CT scan. And based on this, we divide our empyemas into exudative, fibrinolent, and organized stages. And we can adopt a stage-directed treatment where exudative phase undergoes just drainage, fibrinolent can go early VATS, and a organized stage, if the pleural peel thickness is less than 10 mm, then we go for VATS, or if it is more than 10 mm, we go for open decortication. Similarly, as I talked about, this is our recent study, which is you are going to see in the Journal of Indian Association of Pediatric Surgeons, and I thank Dr. Basu for supporting this. This is a study based on 10 years our experience with Wilms tumor, because our presentation of Wilms tumor is not only it is higher stage, but also the size and the volume of the tumor is very high, and we have a difficulty of not crossing a definite number of outcome. The survival rate has not majorly increased in last 10 years. So this is something which we worked upon, and we identified the practice gaps in the management of Wilms tumor in the resource constrained setting. And we have come up with a very good article, which will be published probably in January. At times, we work together with our general surgery or super specialty colleagues. One example I would like to show about cross specialty transfer, where we use the anti-sagittal approach, that is ASARP, Dr. Waklu's approach, to help our oncosurgeon friend, especially for ultra low rectal carcinoma, where we have done plenty of cases so far, and we help them to do a low dissection, intersphincteric resection, and a hand swing anastomosis, saving the cost of the stapler, as well as making it feasible for very low types of rectal cancer. Now, at times, the Western criteria of assessing any particular study is totally different. Like they use AGRI or GRID methodology to quantify the quality of the article. But in both these two methodologies, there is no consideration of the geographical inclusion and economic implications. So recently, as so many guidelines emerged during COVID-19 pandemic, we devised one emerge tool considering the needs of low middle income countries, where we divided into 6 categories and considered geographical inclusion and economic implications also. And this tool was very well accepted by British Journal of Surgery. So when I conclude, so what I would like to share with my younger colleagues, especially, like we do a lot of work in even in resource constrained settings, there is definitely a place for innovation, research, publication. With the type of work you are doing, you should never get disappointed. You should publish and prosper rather than do not publish and perish. But at the same time, we have to keep in mind, art of surgery cannot precede the science of surgery. So science of surgery in the form of efficacy, safety, and ethics should never get compromised. Thank you very much. If you allow, I can show that transperineal meconiolysis video if you allow me.
How long is the video?
30 seconds video, sir.
Okay, please go ahead.
Can you see the screen?
We can.
But there's no video.
Can you see the video now?
No.
Okay.
We can see your open folder and there are 5 videos there. So, but that is not moving.
Problem. I don't understand, but I'll share on the YouTube. I mean,
you can switch off your own video and then try. Maybe some bandwidth is saved there.
So I can share that YouTube link to you all. It's a video which shows the feasibility of one-stage anorectal malformation pull through, laparoscopic pull through. So I'll pass it on to the chairperson for further this thing that they can invite the questions.
Vikesh, your idea is well taken. Well taken. I will request Santosh to start the question answer if he wants to.
Thank you, Ashok sir. Thank you, Vikesh sir, for a very crisp and innovative lecture. What you said, new innovations and research in a resource limited settings is very important. We have to adapt to the situations as you said, sir, and
Right.
do the best to the children who come to with us with many congenital anomalies. So we have to keep on thinking and innovating. And innovative things and research both go in hand. Research will not include innovation, but innovation always includes research. Thank you, sir, for a nice lecture.
Right, sir. Thank you very much.
If there is any other question from the audience.
I have a comment. Can I make one?
Yeah, please, sir.
See, I think most centers in our country are resource strapped. So, and I think any innovation which comes out from any center should get its desired recognition. And I think one of the functions probably of the research section should be to monitor, particularly the Journal of Indian Association of Pediatric Surgeons, where most of these innovations are published. And possibly as whether you could include it in the newsletter of IAPS, or maybe send a separate newsletter and circulate it to all the people, or maybe alert the people to do. And this can be done maybe once a year at the end of the year, or at your annual conference, so that at least there is a due recognition of the innovation which is happening in resource-strapped situations within the country. Let all Indian pediatric surgeons, and hopefully that will stimulate other people to think and publish more.
Thank you
for a wonderful idea, sir. That's a great idea.
Wonderful.
I would also like to make one comment, if permitted. Yes. I think both the lectures, they are complementary to each other. So the procedural idea for Dr. Vikesh combined with the new technologies that was devised by Dr. Sagar, they can go a long way and are complementary and to be applied for a resource challenged nation as ours.
Before we conclude, I must say that the Indian pediatric surgeons are indomitable. We will perform our job at any cost, innovating anything. And these instruments that Dr. Sagar has devised, maybe will change the scenario of endoscopic surgery in the whole world. So thank you very much. Thank you, everybody. Thank you. I hand over the
I
proceeding.
apologize for the technical glitches. Usually,
It's not your fault. It's not your fault.
No problem. We are all used to it now.
So on behalf of organizers, it's a small token of appreciation for Professor Vikesh. Thank you very much.
Just don't remove the screen. I will just take a print screen to save in my.
You will get, okay. You can take a photograph, but it's already on your mail.
Yeah. Thank you so much.
Yeah. So, okay, thank you. So with that, we come to end of session 4. And I thank all the coordinators, chairpersons, and speakers. Thank you. Over to you, Dr. Shilpa.
Thank you, sir. Thank you, Professor Semi. That was nicely coordinated. You're one of us, so it's all right. For the next session, I would like to invite Dr. Sarita Chaudhary. We'll be starting 1 minute early. Dr. Sarita is an associate professor of pediatric surgery at Institute of Medical Sciences, BHU, Varanasi. Dr. Sarita, please call in the next chairpersons.
Yes, ma'am. Thank you, ma'am. So very good afternoon to all of you. Now we are going to start our session 5 of this 6th annual conference of research section of IAPS. And this is on artificial intelligence in surgical practice, very important topic. And now I invite our chairperson, sir, Dr. HPS Miglani, sir. Sir is from Miglani Hospital. And Dr. Kuntal Bhaumik, sir, he is from Institute of Child Health, Kolkata. So I just handed over the mic and chair to our chairperson, sir, for further proceeding.
So we are 2 minutes early, so chairpersons can take time to introduce.
Dr. Mahajan, thank you very much for inviting us to chair this session. Just a few words I would like to share with the audience that in the coming years, I think the way science is moving, I am aware about it, being in practice also, and being indirectly a part also of virtual intelligence. This VI is artificial intelligence is catching up very fast with the humans. Although humans are responsible for developing the infrastructure as well as software of AI, and this forthcoming lecture by Professor Mahmood Al-Fiqi would be, I think, very enlightening and very interesting. My better half is doing AI protocols in pathology, and she is heading this lab in North India, SRL lab, and she's providing very inputs about identification of particular types of cells from the slides, and so many other workers are also giving their inputs. So the machine will be able to tell, okay, this is a neutrophil, this is a lymphocyte, this is a malignant cell, and this is a benign cell. So that they are actually letting the machines take over the humans. So in coming years, mark my words, we all will be redundant and we'll be all dependent upon computers and robots. So thank you very much for giving me this opportunity to chair this session. The organizers can proceed with the proceedings.
Thank you. So Dr. Sarita, Dr. Khizer, Dr. Mahmood.
Thank you.
Dr. Kuntal, please introduce Dr. Mahmood.
Yes. Thank you, Professor Mahajan and Professor Shilpa Sharma. Artificial intelligence is gradually changing the practice of surgery with technological advancements in imaging, navigation, and robotic intervention. This is a very important topic, and Professor Mahmood will talk about artificial intelligence in surgery. His brief achievements is from Harvard Medical School graduate of Global Clinical Scholars Training Program. He is Administrative Secretary for IPG Middle East Chapter. He is also WFAPS Webmaster and Executive Board Member, Country Lead for ASOS, global pediatric surgery, and many more research studies.
Hello, everyone, and thank you for the opportunity to present here. Thank you, Dr. Shilpa Sharma, for the opportunity. I hope the mic and the voice is clear. Can you hear me well?
Yeah, well, welcome.
And you can see the presentation well?
Yes, welcome.
Okay. So I'll be talking about artificial intelligence in surgery. I come from a pediatric surgery background, but I hold my MD was in general surgery. And I've been through, I'm associate professor of surgery at Cairo University. I'm also have a research degree from Harvard and the deputy director for skills research center at Cairo University. I'm also the secretary of the IPAC Middle East chapter and digital coordinator. So I know a few about digital and social media and a few directions in artificial intelligence around the world, as well as the RADCAP, which is a data collection. So it all pulls up back to data and artificial intelligence. So what is artificial intelligence? Everyone talks about how it affects our world, how it works. It goes back to a scholar called Alan Turing, who invented the terminology, and it was discovered by John McCarthy back in the 1960s. Artificial intelligence mainly means that numerical calculations or data with the aid of a computer can form a sort of a biological intelligence of computers. And there's three objectives which mainly summarize the whole concept. The computer analyzes the data, it understands what it means, and then it predicts where it's going. And this is basically how a human brain functions. There's an input, there's some processing, and then there's the output, and how we can predict to see where it's going and how we're going to react to a situation. Machine learning is one of the concepts of artificial intelligence, which means that we can learn what's happening and then make predictions by recognizing patterns. There are two concepts there. There's supervised learning, where you teach the computer how to know, where you label the data, and then the computer will make an algorithm or a function or what we call an equation, so that can predict and have an outcome in the future. It's basically statistics and computer data computing. And there's unsupervised learning, where you just give a whole big data set to the computer, and then it analyzes this and brings out an outcome. Both are called machine learning, and they're the basis of all the examples and all the applications that we're gonna see later in the presentation. But these are big words everyone's been using, and there's a need to simplify the data to surgeons as what they really need. There's a natural language processing, which means that we have to keep teaching the computer what the natural language is. These are important in that the computer knows when it reads the medical records, what does an ICD means, what does all the languages mean, the names of operations, the names of surgeries, so that the computer can go through the electronic medical records and extract certain words and phrases and build up a dictionary that can be used for further data production and further data analysis. This can also improve words like improved billing, improved patient functions, patient outcomes. How can we know that where this is going with the patient, is he's going to survive or not? So it's called a natural language processing. You're teaching the computer and the data of the computer what does it really mean, and put it into equations that it can process it into a further process. Again, one of the big terminologies on artificial neural networks, it's like it was inspired by biological nervous systems, just like our brains. What does it mean? It means that we can make a more complex, subtle patterns when we analyze the data and put it into more equations, so that we can make a further decision or a better decision regarding this surgery or regarding this outcome of an operation or outcome of this procedure. So artificial neural networks, again, is a very complex procedure, but it's very used, the word is used anonymously. And we're gonna give a few examples on how it was used in surgery later to make further decisions and improve our outcomes. Many people think that only the computer knows, or only the artificial intelligence is only involved in radiology, but actually it's all connected together. So the computer vision, analyzing the images or video streams into data as color, texture, and composition, putting into an equation to make a data set that can see how the outcome and how the patient will improve and where this is going. And this is mainly in radiology. It's used in robotics and surgery. It's made a lot of applications in surgery nowadays. And you can see this how it's a concept and how it's working, that you can see the surgical images, they're automatically rendered or analyzed so that the computer can understand what it means. There's the bleeding here, there's no bleeding here, and put it into an equation so that when it sees a bleeding later or a function or a tumor, it can blip like an alert or go later. And again, we'll explain it thoroughly in the presentation. There's a few concepts in artificial intelligence. There's a hype about it everywhere, and there's some ethics that were concepts to explain so that we can move on and improve how we deal with all these outcomes and how we use all that artificial intelligence and robotics for the better of humanity. In 2018, the European Group on Ethics, the EGE, and Science and New Technologies, they published a report that there need to be a statement on the ethics that the artificial intelligence in surgery and in medicine overall should enhance social justice globally, and that all mankind should benefit from the promise of AI. But the most important thing that they have stressed upon that is that the use of artificial intelligence and robotics in surgery should lead to what we call in the future as autonomous surgical systems. And this is what we call in the future, or what we see in all the movies, is where the robots are performing all the surgeries and where they're going to and how they work just autonomously and individually without any human intervention. Of course, it will take a few years, a few decades until the computer, the artificial intelligence learns how the surgical procedures are done. But we're going through that, and these have to be done through the ethics and through rules that cannot be broken later. And we'll explain how robotics are working synonymously with surgical systems. Also, there's the new technology that are coming up that have influenced our governance about artificial intelligence. They have least increased stress upon the surgeons. So the surgeons feel that they've been left out. You don't know about the terminologies, you don't know about the new technologies. There's a few absenteeism, people working on these technologies coming out, the social media, electronic and medical records, filling data systems, data compliance. I mean, these all have led to overempowerment of surgeons and feeling like an empowerment enslavement paradox. It was published last year in the JAMA that there are many new technologies that have governance the way surgeons think and the way surgeons are living right now, adding more stress and burnout to surgeons, which lead us that this whole technology has to be taken more slowly to be adopted and so we can reach a good adoption of the technology and we can reach somewhere good. The thing is called the Gartner hype cycle, which includes that there's an inflated expectations and stress upon the surgeons, which was launched with the minimally invasive surgeries back in the 80s, and then the robotic surgeries in the 90s, and then with notes, and then now with machine learning and deep learning and all the artificial intelligence concepts. This has led to a cycle that the surgeons are feeling stressed out and burnout, and then reaching one source of disillusionment. Will this really work? Do we really need it? Are we going somewhere with it? And then onto adoption, where the surgeons and the medical physicians have already accepted these concepts and have moved on to more adoption and more integration in their surgical services, and in the end, providing a productivity and endorsement of these services and these technologies. So one big concept in artificial intelligence is robotics in surgery. And these will produce, in the end, in a few decades, maybe in our lives, that autonomous surgical systems. I'll go through a few concepts that have already been adopted. We all think that implementing artificial intelligence surgery means that robots are doing all the work. But actually, right now, in this decade, they're actually helping us with a few advantages in our procedures. They're providing 3D images of our surgeries, live surgeries. They're giving better ergonomics for the surgeons. They're giving the ability to control a third arm or maybe fourth arm or for support, and many degrees of articulation that would have been adopted with a surgeon. But again, it comes with a few disadvantages as loss of haptics, loss of 3D presentation, and the inability of the surgeon to be in constant contact with the actual patient. Again, these are small disadvantages, which I'm sure will be passing on in a few years. So many MIS procedures right now have already been automated, a few surgical concepts in them. There's already an operating room linked with robotic arms and laparoscopy. There's already the automatic staplers have been adjusted to according to the tissue of the staples. A few sensors in the staples that know how big or how thick is the tissue to be stapled. So it adjusts the type and size of the staples to be stapled. These applications have helped to shorten the learning curve of surgical procedures with fellows. It has helped to push out more to do better surgical procedure with better safety for the patients, as well as for the anesthesiologist and for the whole surgical team. And it has led to an excellent real-time evaluation of how the trainees are learning and how the surgeons are learning new procedures and how we can improve our surgical procedures, as well as when they're connected to the sensors and to a whole computing system, all this data set can provide outcomes for the surgery and how this can move on. This is the best video I could find out. It's not an endorsement of the Da Vinci system, but it's the best I could find to explain the concepts and how an operating room is all connected to artificial intelligence to the whole system. Another concept in robotics and surgery and how it's used in the OR is augmented reality. Already, it's been adopted in many centers, and I mean, augmented reality is already there in video games and Facebook metaverse, where they superimpose imaging onto structures so that the surgeon can know whether he's working in open or in minimally invasive procedures. The surgeon can know the important structures. He can see how it's going. He can highlight the tumors. He can know where if it's connected to the CTs of the images of the patient, the surgeon can know where the lesions are in the hepatic lobe or in which lung, so that to focus on which part of the surgery. It enables guidance to the surgeons to where the relationships of all lesions and all structures in real time, so that to improve the quality of the service of the patient and safety of how the procedures are done. This is implemented in hepatectomies, already in spine surgeries, sleep gastrectomies, aortic aneurysms, mastectomy. I mean, it's done in all surgical procedures now, whether it's open or MIS. And it really starts from a basic augmented reality software program to implement a whole integrated OR system. Of course, this improved the benefit. Of course, it has made a lot of benefits for the trainees, better even than the 3D systems 3D printers that were a trend a few years ago. There's better training efficiency for the trainees, better mentorship, better playing of videos in the background, improved tissue handling. There's sensors in the tissues in the instruments, so that the trainees and the superior surgeon can know how the trainees are handling the tissues and guide them to better handling. It reduced errors when compared to traditional apprenticeship methods, more mentorships, better instructions, better workflow. Also, the 3D printers, we've seen how they've advanced, but integrated ORs and artificial intelligence applications have really pushed these to a further level after 3D printing. And of course, this all leads to preoperative planning and practice and operative procedures and post-operative outcomes of the patients. The other concept is artificial neural networks for better decision-making, which pushes a step backwards, which is for the better of humanity, of course. The surgical decisions in laparoscopy, for example, and the operative have been using using augmented reality and artificial intelligence to guide and to identify landmarks and risky structures to avoid making complications and making the surgeries smoother, as well, and improve the surgical workflow and decreasing any complication rates. And there are few studies have been published about how the duration of surgery can be estimated, and the risk of bleeding, the risk of complications, just by analyzing how the workflow of the patient, of the surgery, how it went through the whole surgery, I mean. And with the University of Pennsylvania, they had a post-operative outcomes app or a post-operative outcomes calculation on how the risk of incisional hernia or other complications, just by analyzing the workflow of the patient and workflow of the surgery. And through the data and artificial intelligence predictions, they could have an outcome of how many patients would have risk of incisional hernia. And even on the survival, in some tumors, as in pancreatic cancer and GIT cancers, they could estimate through the operative, the preoperative, operative, and many risk factors where this is going to predict the outcomes of the patients, even though these are just, I mean, we've never had intraoperative data calculated or captured just before that. Now we have a very actual and very clear and detailed workflow and duration and many parameters in the surgery that we can evaluate to see how these patients will survive later. Again, there's a 10-factor predictor Bayesian network website that has been production by the University of London, which shows how the risk of revascularization in trauma. They've added preoperative and postoperative data. You can just use a calculator to know how to predict where your patient revascularization outcome and survival will happen to these limbs. And again, in ophthalmology, lots of applications in keratoconus with a few factors that can detect if this patient will have keratoconus and if it will improve, or if the patient with all these factors will have a keratoconus later in his life. And with LASIK surgery, they reach 93% accuracy with prediction of post-surgical ectasia just by analyzing the intraoperative, operative, and postoperative data from the LASIK machines. These are all artificial intelligence applications. With every patient, with every data, with everything added together, we will reaching bigger data sets and bigger outcomes in the end. In GIT tumors, even they can predict there's a predicted presence of malignancy. I mean, with evidence of the data, analyzing the data in radiology, they can see if the patient, if these lesions already have a malignancy, or if how would they respond to treatment, even just by analyzing the data from the imaging, which puts us into a whole few different game on how radiologists will be dealing the next decade. And in the breast, with screening, it has less time, more accuracy, and more doctor-patient interactions, so that the doctor can have more BI-RAD and better improvement of all these BI-RAD and the staging systems to see if, just by analyzing the data, where this is going. Even in our center at the Qasr Aini Faculty of Medicine at the Cairo University of Medicine, we're heading right now a new project. It involves intracranial hemorrhage study. So what we have is we have patients coming in for head trauma. We do a CT brain for the patients, and then the data is sent to an AI software that detects where the tumor, where the hemorrhage is, and you can see in the upper image it is a software. It's detecting there's a small hematoma and it shows where the soft tissue is at the brain, where the hard tissue is, and where the hemorrhage is. And then the AI sends a notification to the radiologist, to the radiology department and radiology staff to alert them that this is a critical patient. It sends an SMS to the neurosurgery team to prepare that this is a patient, and to the OR to prepare the OR that the patient is going to come in a few minutes. So everyone is alerted and everyone knows there's a critical patient in the building. Everyone should just be alerted to be ready for the patient to move on to post-surgery. In the next step, we hope that this AI will detect multiple organ injuries as the patient goes into the CT scan or the MRI. The data will be collected for multiple organ injuries, so that more notifications can be sent to the radiology, to the general surgery team, to the orthopedics team, so that everyone's prepared to move into the patient as soon as the patient is already in the surgery, is in the CT. And hopefully, at some point, that the AI works without any radiologists intervene, like in late shifts, like in urban areas, rural areas, when there's no specialist radiologist available, just a technician. So we don't rely on the technicians, just all the AI does all the work to alert everyone that this is a critical patient and everyone should be ready. We've seen the past year and how social media is affecting artificial intelligence, and you'd be surprised that it is already incorporated in our everyday life in surgery and medicine. So the PRISM patient-reported information multidimensional exploration framework was going through social media, analyzing the data that was coming out through the past 2 years. And as soon as the WHO declared the COVID-19 as a global pandemic, the tweets on Twitter were tripled about how people talking about the COVID and about artificial intelligence, about healthcare in general. So they put algorithms into classifying all the machine learning algorithm to classify all these sentiments, whether it's positive or whether it's negative, and to put it into, should we go into 8 different emotions, whether it's anger, fear, anticipation, trust, surprise, sadness, joy, and disgust, about where this is all going. And you can see that fear was the most recognized sentiment. People were already, they couldn't understand where this is going. People were very afraid about it already. People with already treatments were already more afraid and were already concerned. So this added a whole different burden on patients and on healthcare workers, which again would lead to a decision that we could, for the WHO or for institutions or for all the stakeholders, to plan and provide interventions on how we can handle this pandemic and how we can handle global events that just through analyzing tweets from Twitter. And again, even for the normal or the regular stakeholders, the regular public population, just to provide emotional support to each other on how we can move on to cope and adjust to all these, to COVID and to any pandemic coming on. And again, this was all just by analyzing tweets from Twitter. They also analyzed a few data from Instagram, which showed that there were signs of depression, that people started adding more filters and more Instagram photos that had more toward darker and gloomier and grayer images. This was just through analyzing thousands and millions of different Instagram photos, just showed that there's an inclination for depression, market depression, going through COVID, and which again is quite interesting to know that all the social media and all our pictures are just analyzed easy as a big data sets. So thank you for your time, and I hope I've been punctual. Thank you.
Thank you, Dr. Mahmood, for an excellent talk. We enjoyed. Before I hand over to Dr. Miglani, only one question. What are the legal issues involved in artificial intelligence?
So it depends. So there are more of ethics. I mean, it depends on the ethics. So the major health concerns or legal concerns already addressed in each country, like the HIPAA, data privacy in the US. I mean, it's the same everywhere. But there's a few ethics. I mean, it's just, these are broad lines to govern how we deal with artificial intelligence and how we move on to make new technologies. Of course, with any research or with any moving on, you have to obtain ethical committee approvals. You have to obtain to maintain the normal, I mean, research ethics. I don't think there's anything else to add.
Yeah, that was a wonderful lecture, Dr. Mahmood.
Thank you.
What is fiction today is reality tomorrow. That we have already learned from our experience in the past. What we are seeing today was fiction just a decade back or maybe 2 decades back. And people used to write fiction novels, and now those novels are coming out to be as real. And yes, we are wondering how come somebody had predicted Omicron 20 years before, which we are seeing today.
Yes.
So artificial intelligence is a cumulative intelligence of all human beings fed into a machine. And actually, the machine can analyze and even give you super intelligence. Like this, I am aware of a study where they have accumulated the data about retinoscopy. And the machine gave an output that a particular patient has so much risk of coronary artery disease. Now, an ophthalmologist can never predict, even in his dreams, that a patient whom he is examining for retinoscopy, he can have a prediction about coronary artery disease. But the artificial intelligence by cumulative data can predict
which patient is having what risk of coronary artery disease in the coming times. So these are the advantages of artificial intelligence. It can see beyond human intelligence because we have multiple sources where we feed the data into the computer, and the computer can analyze other risk factors also, which we normally do not consider as humans. We cannot think that much, but AI will definitely open new vistas, information, knowledge, as well as improvement in treatment. And
of course,
side, it will also have negative aspects on military intelligence and other things. If it falls into the wrong hands, it can be misused also. So it's a double-edged sword. We have to draft ethics, take government into the loop, and then develop all these technologies so that the human race is benefited by artificial intelligence rather than it wipes out itself by artificial intelligence. Thank you, Dr. Mahmood. And
welcome. Thank you.
The organizers can take further.
Dr. Dhruv wants
Dr. Ghosh has one question. Please unmute.
Yeah. Thank you, Dr. Mahmood. That was lovely. Very interested in your initial part of your presentation on machine learning. I guess you will be using machine learning in terms of decision making, not just in surgery, but prior to surgery, and then decision making post-operatively. How do you then validate your machine learning tools? And have you had the experience of using machine learning in low and middle income countries where it might be, because the need might be much more than many high income countries?
So in our study, the neurosurgery study, what we've done is we've got about 200 patients, and we've got our fellows, not the residents. We've got fellows going through all the cases again, and we've been comparing about how the accuracy of the model was working in compared to normal human eye and to normal human interaction. And the specificity and sensitivity should be above 99%. I mean, if the model is working. There are lots of models working out there. I mean, open source and open technologies models everywhere over the world, but it's how you train the model and how you implement it and how you work the whole system to work together with your preoperative and operative and postoperative applications. And this is the most important as we see it.
Thank you.
Welcome.
Thank you, Dr. Mahmood.
Actually, I just wanted to one word more. See, when I was beginning to learn laparoscopic surgery, a place called Johnson & Johnson Institute, I went there and there was a working model of laparoscopic cholecystectomy, laparoscopic hysterectomies, and people were working on that model because of artificial intelligence. I learned my basics on that machine by attending a course there. And it's been long amongst as AI, but we have not formally recognized that so far. But now that it's coming in a bigger way, so it's becoming more and more prominent for us. Yes, Dr. Mahajan, you can continue, sir.
So if there are no other questions, thank you, Dr. Mahmood, for your lecture. Very futuristic. And let's hope artificial intelligence is applicable in a bigger way in future. On behalf of Organizing Committee, myself, Shilpa, and our EC members, we thank you very much for joining us and delivering a wonderful lecture. This is a small token of our appreciation to you. Thank you very much.
Thank you.
Thank you so much, sir. Thank you so much.
Thank you, organizers, for giving us this opportunity to chair this talk, please.
Dr. Sarita, you can take over.
Yes, sir. Thank you, Chairperson, sir. And now we are going towards second lecture of this session. And this is also related to our artificial intelligence. And now we have two chairpersons, sir. Dr. Sujit Chaudhary, sir. He's a very eminent and known pediatric surgeon consultant in Indraprastha Apollo Hospital, Delhi. Dr. Subhashish Saha, sir. Sir is consultant from AMRI Hospital, Kolkata. So now I handed over the session to Chairperson, sir.